Hello and welcome to the group room where we're at the 34th annual CTRC AACR San Antonio Breast Cancer Symposium. So now I'm joined by Dr. Leslie Botnick. Dr. Botnick is a board-certified radiation oncologist practicing at the Center for Radiation Therapy in Beverly Hills, California. You're also the co-founder and medical chief officer of Vantage, Oncology. What does a woman diagnosed with breast cancer really need to know in regard to radiation therapy? Some of the key points that you need to drive home to these women. You have very different types of breast cancer.
That you need to have the appropriate equipment that can deliver IMRT if needed, but not necessarily always the case, but can do image-guided radiotherapy, where you can actually ensure that the position on a daily basis is correct, that the planning process includes some positioning device for stability of the patient on a day-to-day basis. As you know, and what we do is make sure that the heart is not in the field, that the actual treatments themselves, you're here, you should be in the department no more than a half an hour. The treatments take 5 or 10 minutes. The setup takes it should take as long as the treatment. And you come and go by yourself. There is no nausea, there is no vomiting. The side effects during the radiation are slight redness and itchiness of the skin. It's rare to blister, rare to have an infection long term. Most women can't tell which side was treated, with normal sensation, normal appearance, and just looks normal. The main side effect you see over 10, 15, and 20 years is some loss of stretchability of the breast, which some women say gives them a young, perkier breast.
And one thing which surprises people, and you hear this all the time, someone's going through radiation therapy and loved ones mean well and they say, well, you know, it's not chemo, it's not a big deal. And you know, well, for the patient, it is a big deal. You know, it's every day, and fatigue can accompany radiation therapy, just like any cancer treatment. Your hemoglobin is impacted. I've always wondered why actually the hemoglobin gets lowered.
I'll correct you a little bit. It's not quite the hemoglobin, it's actually the white cell counts, because there are cells that will circulate within the field of the radiation, and you can see some decrease in the white cell count. You're not immune suppressed, you're not subject to infection. Why some women get tired, I don't understand, but I have found that more you get back to your normal routine, exercise, and get out, that's less of a side effect. We do not see a large component now of fatigue. It is a big deal, because it's got to be done accurately and done well, and you should have it be at a place that really follows their patients, because the issue of not coming back and seeing the radiation oncologist for, you know, when you should get a mammogram, should you have a mammogram or an MRI, should you get this before radiation starts, what you should do, and just the side effects and the follow-up should all be done, you know, in a joint way with a surgeon and a medical oncologist.
If the medical oncologist or surgeon has not referred the patient for a consult with a radiation oncologist, what do you say? Because that patient then maybe has to be the one to become assertive.
You know, I personally believe that no woman today should get any more than a biopsy without seeing a radiation oncologist, first with the surgeon at the same time. And I think women would be better served if they would do that.
And even if a woman is told that they should have a double mastectomy or a single mastectomy, it would seem to me reasonable that on their own, speaking to a radiation oncologist to understand what their options are, to be sure also that certain decisions that one makes, they can't reverse.
That's correct. I think you need to get all your information, and the only way to do that is actually to speak to all the deliveries of care and service that should go to you. I think patients forget that doctors actually work for them, so they get very nervous about insulting their doctor or all that other stuff. We work for the patient. We could be the patient. So, so we want to make sure that we deliver the appropriate service. There shouldn't be these barriers to making these phone calls. I'm insulting my doctor. Hey, you know, doctors work for you. Any doctor insulted by a second opinion is a doctor you probably shouldn't see.
You know, just in the area, like in the area of medical oncology, where you have medical oncologists that will specialize or spend more time dealing with a specific tumor type, is it not so that radiation oncologists, one may be, you know, more involved in treating breast cancer, another more involved in prostate cancer? Is there a benefit to seeking out a radiation oncologist that really sees a lot of breast versus the other types of cancers that get radiated?
With the complexity of therapy today, the answer is yes. Probably 20 years ago, I would not have said that. But how you contour the breast, how you contour the nodes, just like it makes a difference in how you contour the prostate or in head and neck, how you do that, the tumor, sparing the tissue, what you spare, what you do. Absolutely. I think it is very important to be with a physician and a group, if you can, that really has the best physics and dosimetry and people doing this.
And someone who is receiving radiation, people ask this all the time, are they of any danger to their loved ones, to their children, to their spouses?
They're not radioactive. There's minimal scattered dose to the rest of the body, so the exposures are clearly so much less than they used to be. But they're never radioactive unless you have radioactive material placed in you and you walk out with it. Since even with the brachytherapy, it's done in the department, you're emitting no radiation.
And what about radiation therapy in pregnancy, and if you are pregnant at the time of your diagnosis?
If it's an early pregnancy, that's the most dangerous time to get the radiation, so most would not do that at all. We usually try either to get people past the first trimester. If we can, they'll do the excision, they'll do some chemotherapy. We try to delay radiation till after delivery, but the safest time is probably in the last trimester, as crazy as that sounds, because the baby's formed, there's very low scatter, and if you had to use radiation, you could do it at that time. Most of us try very hard not to use radiation during pregnancy.
Thank you, Dr. Botnick. Dr. Leslie Botnick, co-founder and chief medical officer of Vantage Oncology.
Thank you, Selma.